It has a basic three component. The Da Vinci robot has a basic three component. One is your surgeon console. This is surgeon console where surgeon will sit. It may be in the same room, it may be 4 meters away, it may be 4,000 miles away. It is having the capacity you can connect with the internet. But why internet has right now there is one problem, that you have the time delay, and that is 4 seconds. So suppose if you will attach it from the USA, then the command it will take at least 4 seconds time to reach there. And that is because it is going from the normal internet. If you go, it has a different relay stations. Like suppose when you are sending the email from here to USA, directly it is not going to the USA. It goes to Singapore, from Singapore it go to France, from France to Germany, and then UK, and then it goes to the USA. But our scientists they are ready to launch the especially designed surgical satellites, and that will be very useful for the telemedicine and the telesurgery. And that way all the robot will be directly transmitting it to the satellite, and from the satellite it will directly go to the surgeon. So that way this time delay can be minimized. Another portion is this is robotic arm. This robotic arm, which is right now it is draft, although this draft was on the previous surgery only, but we don't remove within the surgery because to protect it from dust. And the next surgery again you have the draping. Draping dikhao. So you have the different drafts. It is coming completely autoclave, and you can just attach and you can take it out and you can drap. How to drap it, I will show you later. So this is the robotic arms. This is the patient side card, and this is vision card. This is vision card. Vision card is used for the assistant surgeon. Surgeon will not see that. Surgeon will see in the console. This is for assistant surgeon, so that during the surgery he will also keep on seeing your procedure. But remember, in the vision card you don't have 3-dimensional vision. Here you have 2-dimensional vision. And in the vision card also you can do proctoring. You can put with the finger, you can draw the lines, and that line will be seen by the surgeon. And if there is a mic on the top, and there is a speaker also. So if you are speaking anything,
Dr. Bari, can you please shift to the other chair?
suppose if it is on the
You
same,
can sit here. Just shift.
suppose it is on the same room, then you directly the surgeon is listening. But suppose it is on some other floor or other city, then it is a two-way communication, audio-visual communication is there. These are the different dappings. These are the instrument arm drap. Then you have the camera arm drap, and these drappings you can use in the different purposes. Like ideally every time. But do you know what we have done to minimize the cost? We have with the polyester clothing, we have designed the drap like that. With the complete polyester, transparent polyester clothing. And then you can autoclave it also. Because the cost of one entire draping is $100. That is approximately 5,000 rupees for draping only. So this way, once you will buy the new robot, then they give you 50 drapings free at that time. Now, first instrument is the telescope. This is basically a stereoscope. We should not tell it as a telescope, because if you see, it has 2 rod lenses and 2 row of the fiber optics, and here you have the 2 eyepiece, and both the eyepiece is image taken separately from inside. This is 30 degree, and then you have 0 degree. This is 0 degree. In 30 degree, suppose you are doing ventral hernia surgery, you can fix it up so that you can see the anterior abdominal wall. If you are doing hysterectomy, you can fix it down. Or if you are doing cholecystectomy, so it has the same like laparoscope. It has a possibility that you can move it in up or down to add 30 degree extra field of vision. Now you have the instruments. Before instrument I will show you the different cannulas. For the telescope you have to use 12 mm cannula. Because telescopes are 12 mm. There are 5 mm telescopes are also available. But 5 mm telescope doesn't give you the stereoscopic vision. It will give you two-dimensional. Because in 5 mm it is not possible to set two row of rod lenses. So it will give you two-dimensional vision. It is used sometime in the pediatric robotic surgery. But for the adult this is 12 mm telescope. Now this is the telescopic cannula. And these are the cannula for the instrument, endorist, for the operative cannula. These, even in the telescopic cannula, you can use 12 mm reusable. 10 mm it will not work. This is 12 mm reusable trocar cannula you can use. But for operative, you have to use their cannula. You cannot use disposable here. You know why? Because this is a remote sensor. And in the remote sensing technology, always it moves around this. It will not move from here. It will move from here. So suppose if you will put that much in, then it will give pressure over the abdominal valve. Because always the robotic arm wants to keep this remote sensor in the neutral position. This is the fulcrum. And around this it moves. And without giving any pressure. So you have to use their cannula. These cannulas, this is a specially designed valve. There is just like the flap valve. This is flap valve. So air will not leak. And you can attach these valves to these cannulas. And then you can use the instrument. Suppose you have to use laparoscopic instruments. During the robotic surgery, suppose you want to suck the blood, or you want to drop the needle, or you want to use any of the aspiration needle for ovarian cyst. In those situations, this is a valve, you can attach it and take the robotic instrument out, and laparoscopic instrument can be introduced into that. And your assistant can suck it, or your assistant can puncture it. So there is no problem. And at that time, this cannula will be held by the robotic arm. So there is no fear that it can come out if you will use the laparoscopic instrument. How to do, I will demonstrate you. Now, these are the valves, and these are the obturator or trocar for these cannulas. So these trocars can be directly introduced, and here you can lock it. You press it, it is locked. Now it is locked. And you will hold it same way how you are holding in the laparoscopic, and same way it should be perpendicular. It is important that introduction should be perpendicular to the abdominal valve. You should avoid making any track. You should avoid making any tunnel. If you make a track or tunnel, sometimes it tears the peritoneum. Because in laparoscopy, you have the tactile feedback. You will know, even in laparoscopy, making a tunneling to the pre-peritoneal is not good. You should go initially perpendicular, and as soon as the tip of the trocar has anchored the peritoneum, then you can move it to the free area. But a tunneling should be avoided. Here it is more important. Now the instrument. Instruments are just like the laparoscopic instrument, but it is called as endorist. You can see this is just like a bipolar Maryland. Here you have the cable for the bipolar, and you can attach it here. These two cables will attach like that, and this will attach to the generator. You can directly go through the draping, and generally they recommend to use the Valley Lab generator, because Valley Lab is American, Intuitive is American, so they recommend to use Valley Lab, and it is compatible. The cables are compatible with the Intuitive Surgical. So you will attach exactly same way monopolar you can attach, and it has, you can see the plastic tip, and these are the wheels. These wheels are attached with the wheels of here, these wheels of the robotic arm. So basically it is electronically controlled, and there is one sensor point, and it has an electronic chip inside. So once the command comes, this electronic chip will sense it, and it will work in such a way that it will not allow to use this instrument for more than 10 times. Whenever you will introduce it, it will write 2+, 3+, means already 2 use, 3 use is over. And once you will use 10 times, after that it will write instrument expired. Now you cannot force. In laparoscopic surgery, sometimes even the harmonic probe is actually disposable. But we are keep on using till it works. Modulator, this gynae care modulator gun is disposable. But we do it, we use it. But here you cannot use it. It is only 10 times you can use it. And there is no anything which you can change the programming. Now, it has a different wires going from inside. Like I will demonstrate you, when I am rotating it, it moves. When I will move it here, like when I am rotating, it is moving in this direction. When I rotate, it is rotating. This is the rotation possible. And you can see it is rotating. Here it will bend up and it is opening the jaw. And then this will again bend it down and open the jaw. So this way, combination of these all movement is giving the different type of 7-degree possibility of the movement. Now here you have two opening for cleaning, the bigger and the smaller, and there is one connector. You will connect it and you will flush the saline and antiseptic solution, because this you cannot dismantle. The laparoscopic instrument click line series you can take apart. Sheath can be removed from insert, the handle can be removed separately and you can clean it. But here you cannot dismantle it. So you have to flush the saline here, so that all the blood, all the clots or the infected part will be out. And then you can use the plasma for the sterilization or ethylene oxide, or you can put in the Cytex also. You have this, like this is the atraumatic grasper. Then the other instruments, like this is the bipolar Maryland. Here you have, this is seizures. This is monopolar seizure you can attach. This is again micro needle holder. If you want for tubal anastomosis and all, then you have, suppose you are using 17 mm needle, a small needle, then you can use micro needle holder. This is tenaculum. Sometime during hysterectomy or during myomectomy, if you want to bite the uterus to hold it and pull it, you can use this tenaculum to hold it. But it is 1:1, it will pierce there. So you have to be careful. Or myoma, if you want to hold, to enucleate. This is the intestinal grasper atraumatic, where if you want diverticulum and all, you can use it. So this type of, this is hook. Here this is hook, monopolar hook for cholecystectomy or for myomectomy to cut the serous layer of the uterus, or for colpotomy, anterior and posterior. This is monopolar hook, same way you can use. Then this is the clip applicator. This is just like the titanium clip. If you have, and you can use hemolock. Hemolock is used there. That hemolock, generally titanium is not very much good to use. So the silicone clip like this. This is same hemolock which you are doing in laparoscopic surgery. It will be attached and you can clip it. So this way different type of instruments are there. There are many instruments, like in the box you can see the blue one. All type of instruments are there. Like sometime mega cutter with the needle holder. Then you have the different type of suction irrigation. You have the different type of energy sources you can use.
And that means all instruments, laparoscope, laparoscope,
All
available.
yes,
Available.
all available. Even the harmonics available, a plasma kinetic available. Here, when I am pressing it, you are hearing one sound. This is the knob. When I press it, it gives a sound. And one knob is here. This is also giving a sound. Now, this is the arm movement which I can just keep on pressing, and it is very easy, motorized. I can move in any direction. And this is which I have to move the arm at this level. So you have to prepare the patient card. Now how to prepare? The first thing is that robot has to be, table should be arranged in such a way that the robot will stand on the side of the pathology, as I told you during the docking principle. and then it has a remote control also, and just the assistant will press it and rotate the wheel. It has a motor, it will start moving. Move. Now it is coming nearer to you. Automatically it comes nearer to you and it is over the body of the patient. Again if you will put it back, now it can go back. So this way what it is writing, that ready, prepared patient card for the surgery. So this is how the patient card will be brought near for the surgery. And the patient will be anesthetized. Before bringing the patient card, all the port you have to put your own, just like the conventional laparoscopic surgery. And during the port position, you will keep in mind the baseball diamond concept. Thumb will be in the umbilicus, index finger here, and it is 10 centimeter away. Here is one port, and this will be the other port. So triangulation should be shape of a diamond should form. Telescope in the center, one port here, one port here. If you have to put the third and fourth port, if you have to perform, you can put it 5 centimeter lateral to the nearest port. Or some people they put in between here behind. Suppose you have to use one retractor or suction irrigation or assistant port, you can put in between. So this is the target, this is telescope, this is one port, this is second port. Shape of a diamond should form. And 10 centimeter lateral. And the assistant port may be lateral if you have a space. If you don't have a space, suppose there is inferior epigastric artery, or suppose triangle of Doom, or suppose deep ring, then you can bring it behind, in between these two. Now, once the patient is ready, then you have to demonstrate some points on those monitor. Now I will tell him, he will show you how to do that. How to attach? You will, first you think, if it is 30 degrees, you have to keep in mind you are doing the anterior abdominal wall surgery or the below surgery. You can fix it this way or that way. But if it is 0 degree, it doesn't matter. So now it is fixed. And just you rotate, it is attached. Then you have the light cables. You have the two lights. Because it is a stereoscopic vision. So one light will go here and another light will go there. Okay. Here this is just very simple. These are the two lights and this is CCD attached. You can just unscrew it to remove and then screw it. I will show you once again. This is out. And then you just attach it and screw it. Like normal. There is no any difference in that. And this is also CCD. Now what you have to do, you have to do a scope alignment. Here you have two holes. This is for 0 degree, this is for 30 degree. Central column. And it is setup joint 1. And this is setup joint 2. Now when you are fixing it, you should fix it such a way that this arm, setup joint 1 and central column should be in the same axis. This is very important, especially when you are using with the camera. And do you know what you should do? Here is one sweet spot. If you see very carefully, there is one blue line. And there is one arrow. This is a blue line. And there is one arrow. Can you see that? If this blue line is not in the arrow, suppose it is like this is wrong. This is known as sweet spot. And that sweet spot always should be respected. Here. If it is like this is okay. But if it is going this way, this is wrong. That will limit the movement of the robot. So you must take care that your telescope should be, and the setup joint 1 and setup joint 2 and the central column should be in the same axis. It should not be in the different axis. That is important to keep in mind. Now, for these different arms, there is another principle. That the setup joint 1 and setup joint 2 should have 90 degree angle. And there is one another point there. These 2 points should be parallel. Setup joint 1 and setup joint 2 should be 90 degree. If it is like this, it is wrong. Can you see that? Because both are swording. So how it should be? It should be this way. It is 90 degree now. Can you see now? Both the points are parallel. Ab theek hai? Now it is correct. Now it is okay? Now it is correct. You can move it down, you can move it up as much as you want according to the OT table height and according to the size of the patient. And you can move it towards you also, and here we go. Now, the movement of the setup joint can be done by this button. If you press it, setup joint can move. But once you will lock it, then this is the remote sensing, this will never move. Even if I am moving that way, you can see my finger is there only. My finger will never move. So if you will press this one, it will move the complete robotic arm, but this axis will not deviate. So actually this is coming for your cannula. And this axis, there are two ways of moving the arm. One way, keep it pressed and then move it like that. Another way is just tap it and then move it. And once your movement is correct, suppose sometime you want to use laparoscopic instrument, then remove the robotic instrument, introduce the laparoscopic instrument and move it and do the suction irrigation. And you know, even if you are moving, cannula is stabilized. So this is for cannula will be fixed and it cannot move. And there will be no any pressure over the abdominal wall of the patient. Robot is taking care that this axis should not deviate. It can rotate, but it will not go up, down or left, right. In the same axis it moves. If you will click it, then it is locked now. So this way you have to fix it. Now I am bringing the arm third, and this is the third arm, setup joint, and I am leaving it. It is locked. So this is the position for which surgery? Suppose patient head is there. Then this is for which surgery? Appendix. And it can also be used for right nephrectomy. If the patient is little lateral. Isn't it? Right nephrectomy you can do. Or you can do the right colon surgery. Or you can do cystectomy. Or this procedure. So this is, if the patient head is there, then you can do left side surgery. Left colon surgery, left kidney surgery. If you have to do hysterectomy, then the uterine malbreeder people will sit there in between the arm. There is a possibility of side docking. Some people they do side docking, but ideally it should be a stool there and she will go from this hole and she will sit there. And leg should be stood up. The table should be bifurcated and the leg will be like that. If you are in colic cystectomy, then head will be there. But never mind, you can bring it after putting the port and doing initial diagnostic laparoscopy. And this also can be extended more. It can extend more, it can come more ahead. So it is not a problem. In those situations, it will be according to your convenience, you can dock it. The design is in a way that up to 6.5 feet person can accommodate. So company has taken this care that the arm should be big enough. Now this is fourth arm. Right now fourth arm we have in, and now you can bring it. This is the fourth arm. Suppose you want, suppose you want any other assistant port, then this is the fourth arm you can bring. And that can be used. Now I will show you how to put the telescope and instrument. You should have the telescope, it's very easy. First, before putting the telescope, you have to put the cannula. Right now it is written here, the warning card can move. Means card can move. If someone will try to move it, he can move. But as soon as you will put the first cannula, card will be locked. Like I am showing you, here I am putting the first cannula. and then this warning sign will go. Now you will see this warning. As soon as I will lock, this warning is gone, and then it is locked. Means even if I want to move it, this card now, it will not move, because if it will move, it will tear or it will damage the abdominal wall of the patient, or it can damage some organ. So this is automatically sensing that the cannula is attached. Now it is locked. Now it cannot move from here, and you have to put the second and third instrument. This, remember, instrument should not be introduced with the arm. The cannula is already there, and the arm will come near the cannula. Cannula will not go near the arm. So they have given a small button here. This button I am pressing. Once you will press this button, then you can bring it near the cannula. So suppose cannula is already there, then I will press this button, this will be open, and then bring it now near the cannula, and then now it is attached. And after attaching it, just you lock it. It is done. Very simple. And it is very easy. It doesn't give any force. Easily you can bring it here. Now this cannula will not move. This cannula is fixed. Again, same way, you will bring it. This is the button on the back itself. You can bring it there, and as soon as I will press the button, it is blinking. I am pressing the button, it is blinking. So this is the switch for the moving the setup joint. That is just behind the cannula. This is draping, a sterile draping. So there is no chance of any contamination, and here it is attached. Once it is attached, you will lock it. Now it is done. So all the ports are now attached. And do you know, now I can move it. See here. Even if I am moving, remote sensor is still there. See, if you put the finger here, this doesn't move. Instrument is moving, but remote sensor will not move. And now it is attached. After that, we should take the telescope. Here, I will show you. It is very simple. There are two knobs on the back. You can open here, open there, and this is out. And these are the grooves. You have to put this groove inside like that. And there are two buttons, just press it and it will lock. It should be completely in and it is locked. That's simple. It is not difficult. And to move it, I will show you again. To move it, in the back there is one knob. And you press this and you can move it. Like that, it is moving. And bring it near the cannula. If the cannula is already there, you will bring it near and then it is fixed. And once it is fixed, just you press and it is locked. It is simple. So, and after that, you have to drop your telescope inside. This is the telescope and you have to drop it. Remember, this is intuitive return. This intuitive should be towards your patient card. If you put it like that, it is just like rotating the CCD. So it should be upside down. Bowel will look up. You can rotate that telescope, but you cannot rotate the camera. So you have to just go like this and you will drop it. And just drop, the click sound is there. Once the click is there, that means the robot has got its camera in the position. Now these cables, how to orient? There is one clamp there, and this yellow point you have to put over this clamp. This is the yellow point, just to put over the clamp and it is done. Now this will not break and the weight it can tolerate. Now how to put the instrument? For the heat increasing now the intensity of the light. Now how to put the instrument? We can see here, suppose I have to put little more in, you can do from there. But suppose I am the surgeon, I will click it. And I can push the telescope more in. Can you see that? And I can move it like that. So I can do from here also. If I want to see, I want to do my own examination. I will hold this, I will hold this, and I can do the diagnostic laparoscopy by these two. And it is moving. Diagnostic laparoscopy I can do. Once it is done, then again I will click it here. As soon as you will click it, that means now command is transferred to the surgeon who is sitting on the surgeon console. It is lost from here. Now I cannot move it. It will be done by surgeon. Right now you can see there is one cross on the 1, 2 and 3. What does it mean? That there is no instrument loaded. And surgeon also can see in the console that instrument is not there. Now what the surgeon will say, the assistant, that put a grasper, or this is a simple grasper. Now putting the instrument is very easy. Just you have to go and first you put the instrument into this groove. After that you go here and these clamps should be taken care and drop it. Here you can see it is loaded. 9 plus means 9 U's are there. Did you see that? And then 9 plus 9 U's are there. And instrument 1 is loaded. Instrument first is loaded. Now you can press it and you can bring it near the vision like this. This is the instrument and remove it. Now it is done. Do you know when it was out? When it was out, I will show you again. And if you have to take it out, just take it out like that directly. When you have to put it in, just you have to go into the cannula here, and here it is locked. But you will see here it is writing instrument installed but not ready for surgeon. Do you know why? Instrument is in the cannula. Not seen. So the robot wants to see the instrument. So what you have to do? You have to blink it. And then you go and bring it under the vision. And once it is there, then robot has sensed it. And now one number is blue. That means it is sensed. And now next time, whenever, suppose you have to instrument the instrument next time. You don't need to do anything, just you take the instrument out and give another instrument. If you put the other instrument in, हो जाएगा ना, एक दूसरा रास्ता पे So now you will hold it like this here and just you put it. And now just press and automatically it will reach there where it was left. It is memorizing. You don't have to see. And remember, in between if any vowel comes, it will sense and will tell you to withdraw. So next time, now you don't have the problem of finding out the tip of the instrument. From the next time, you can with the you remember it is in the center. It is in the center, and now I am just taking it out and taking the other instrument in, and it will automatically go to the same position in the center. Here it is locked, and as soon as it bleeds, just press it. It is in. It cannot go even 1 millimeter more inside. Not 1 millimeter right, 1 millimeter left. It will go exactly there where it was, from where it was withdrawn. So this is a very good sensing capacity of the robotic arm. Now I am putting the third instrument. Same way, it is very easy. Just you have to go there, just you have to lick it. If I want to find out, I have to click so that it is free now. It is free for me. And then I can go, and you know the technique of going correctly is elevation angle should be same as of telescope, and go with the 45-degree angle you are there. You got it? Without seeing the monitor I am there, and then I can lock it. Here I am there and I can lock it. Now both the instruments are ready. Now what it is writing, and everything is programmed. Task analysis is programmed there. You cannot do the things upside down. If you do the step which has to be done before, it will write it command that please do this thing first. Suppose I will put the instrument before telescope, it will not allow my instrument to go in. It will ask that camera is not ready, camera will blink. I will show you, as soon as I will take the camera icon will be there. So it has a very systematic software programming to take care of all our mistakes. And now we are ready to perform the procedure. So this is how the docking and instrumentation is done. Now you can have your lunch.
One question.
Pardon?
Question.
Yes?
During laparoscopy, first we put the telescope, then the other parts.
Yes.
Here.
Here also, do you know, first you will put the telescope, same telescope without attached with the arm. And then you will see and you will put other port. And then you will bring the robotic patient card.
What about
No, this telescope. But you will not attach it.
Keep it.
You got it. You keep it on the patient, this telescope, and do diagnostic laparoscopy. And if you think that robotics is not possible, then with this telescope only, with this monitor, you can perform laparoscopy. Of course, it will be inconvenient for your camera person to hold that much bulky telescope. But these telescopes can be used as a standard telescope for performing initial diagnostic laparoscopy, seeing the inferior epigastric vessel, and seeing the safe point to put the other ports. Did it? And then you can start the procedure.
what about the gas?
Gas insufflator has to be attached. Same way this insufflator they have removed it from here because it may be in the laparoscopic OT. So insufflator, this is the patient card has the insufflator. Same way in the cannula you will attach the gas.
And as laparoscopy, there is fibrous needle.
Yes, same access. Unfortunately, robot cannot do the access. Robot cannot do the access. Access you have to do your own. The trocar you have to put your own. Once all the instruments are in, then it will work. Same pressure, 12 to 15 millimeter of mercury pressure. Same principle of all the fogging, defogging, but it has less fogging, and it has autofocus capacity. So these things are little difficult than the laparoscopy, less difficult, but the same. But now once the instruments are in, then robot itself will control the camera. You can go in, you can come out, you can rotate right, left as the camera person. No tremor. Camera person sometimes give tremor, and there is degradation of the eyeball movement. Eyeball is degraded. It is moving, jerky movement. That will not happen. And your instruments also doesn't have tremor filter.
And the same principles for tissue retrieval.
Tissue retrieval same. You have to hold it. Suppose I don't want this instrument here. I want laparoscopic instrument. एक कोई laparoscopic instrument दे दो. Don't worry. Just you pull it. It will come out. This is the beauty. That automatically, as soon as you will press it, it says that you want to remove the instrument. And then you can put any conventional cannula. But you know, I have to press it. Only one drawback will be after pressing. That it will lose the memory. Now next time, I have to again find out my instrument. This is the problem. Suppose this cannula is in and I want extracorporeal knot. Then in those situations, just you take this washer and put this washer on the top. And now this converted into 5 mm. This is 5 mm. What is the diameter of the robotic instrument? 8 mm. These were all 8 mm. So now this is cannula is in. Then the same 36 centimeter. That is the same. 45 centimeter instruments are also there for bariatric surgery. Cannula also has two lengths. One is 7, another is 11. So now I want suppose laparoscopic surgery to do. I will press it. Now it is free.
Why we have, you want to go to trouble?
No. Do you know why? Do you know why I want to travel? Suppose I have to withdraw the tissue. Or I have to do suction. I don't want to use the robotic instrument unnecessarily, wasting the money. One use. So I will take simple grasper. and I will introduce it. See here, I am introducing it, and it goes like that. And see, this way I can move like that, like that, like that, and I can hold it and I can pull it out.
Even you touch the robot, you can remove this.
No, why I will remove? This is the advantage of remote sensor. Why I will lose the advantage of remote sensor? If it is attached, it will not tear the abdominal wall. It will not lose the orientation. And it is helping me like a gear. And I can hold it. And this robot is holding for me the cannula. Cannula cannot accidentally come out. Cannula cannot go accidentally in. So why I will detach? I will keep it and I will do laparoscopic surgery. I can tie a knot with a knot pusher. I can do whatever. Isn't it? And this is how you can use it as a conventional laparoscopic instrument. Now, if again you want, you go, and this will not do the second count. It is only one count. This reducer I have to remove, and then it is locked. But you have to find out. So with the angle you will go, and once the instrument has found, you will click it. It becomes blue. That means ready now for the surgery. Is it okay?
Always the camera is in number
In the center. Always camera is in the center. Always camera is in the center. It is not possible to keep the camera in one side. It is not possible that camera you can put in another port. Side docking is possible. Do you know how? You will not use that arm. You will use these two arms only. Then it is possible to do ipsilateral. I will not use that arm. I will use camera in one side and these two ports there. That can do ipsilateral. But that doesn't have any advantage. Why I will do that? If I will do that, I will struggle more in surgery. Both the instrument one side, it will be difficult. So both the side is better. You have the more depth perception, better stereoscopic vision. So telescope should be in the center, and both the instruments should be in the opposite side.
always coming for arms, or there's 3 arms or 5.
No, 4 arm is the maximum what we have in the Da Vinci. It has 3 models. One is S. In the S, these arms were black. That is in the M's. That is the primitive model. Now from 2012, company is going to stop that also. So that was the S model. After that, one has SHD. That you can write, it is written SHD. That is high definition. It has 1080 progressive lining. So the vision is good. And the other model is SI. That has the dual console. So you have the 2 console attached together. So 2 surgeons can work together. Do you know what is the advantage? As he was telling, 4th arm, 1 assistant, 1 console, the 4th arm he can retract. Here also you can use the 4th arm, but you have to lift it and make it as a statue. It will not be real time traction. You have to fix it, drop it. Just like the video game, they take the sword and drop the gun.
One user.
Yes. So you can use, because you have 2 hands only. So at that time you can use 2 arms. And the 3rd arm will be static, giving the traction of the uterus or giving some other visibility. So this is the difference between the
So console maybe later for training.
training also. Yes, training surgeon also can see, and he has a 3-dimensional vision. So after lunch I am going to show you the robotic console, how it works, and then we will do some hand-eye coordination.
How long is this instrument?
These are same length as 36 instruments. See there. If you will see from here to there, it is almost same. You see that? It is same. This part is not counted as a part of the length of the instrument. Yes?
Laparoscopy you can use sometimes hand assist laparoscopy.
Yes?
Robotic can allow us to put our hand inside.
If you will put one hand board, you can. Why not?
No problem here.
No
You can
problem.
allow us-
Only problem you have to fight with the robot because it doesn't give you the space to go. This is one of the drawbacks because it is occupying your entire table space there.
No
But suppose
problem.
Pardon? Yes, this is very good. Single incision laparoscopic surgery is possible with the robot. Since instruments and single incision is very much demanding now with the robot. These instruments are, you have the different separate port, and the instruments are going in the same port. So since laparoscopy, it is very much appreciated because you don't have the problem of the robotic control. So now have your if you press it, the instrument jaw will close. If you leave it, you don't have to open. Leave it, instrument jaw is open. This is the left control pad. In that, you have right now 3 instruments active. If you want to use the third instrument, you will inactivate it. If you see here, third arm light is switched off. This is the top. Now, if you are a right-handed person, then you keep the first instrument right. But if you are left-handed, you can keep it to left and you can bring this to the right. It is moved automatically. So, most of the time, this should be right, this should be left. Here, you have the fault override silence alarm. Sometimes, suppose any circuit is any problem, like I will show you, take it as there. I can do the fault override. So I click it, this fault is over, still I can continue the surgery. But you will lose the 3 dimensions. You will have only 2 dimensions. Now if you switch it on, sometimes the fault which you cannot override, like suppose there is some traction over the patient, some traction over the remote sensor, in that situation you can silence alarm. So alarm will not audible. You can silence the alarm. Generally, you should not override the fault, you should try to correct the fault. Now this is the working distance. If you want to keep it nearer, then we zoom. Instrument, the target will look nearer to you. This is normal. This is motion scaling. If you are an expert surgeon, ideally it is better to keep it to the normal. If you are novice, you can keep to the fine and ultra fine. When it is normal, the ratio of movement is 1:1. When it is fine, it is 1:5. When it is 10, it is 1:10. Is it okay? So generally you can keep it to the normal or fine. Ultra fine is not required. This is display. Right now we have 3D display. If you want, you can get 2D. There is no any benefit. Sometimes you are using 5 mm telescope, then you can keep it to 2D. Otherwise it should be 3D. This is a scope alignment. Here you just like how you have done from here, you can align the scope. If you have a diplopia or a scope line is not correct. This is a scope type. If you are 2D, then you will. Right now it is not going to 2D because you have 3D scope. If I will put this to the 2D, then you can go if it has 5 mm telescope. This is a scope angle. If you want to see up, you will keep it up. If it is 0 degree, you will keep it straight. And if you are 30 degree, you want to see down, you will keep it down. This is down. Right now we have attached 0 degree telescope. So you will keep it straight. So this is left pad, control pad. This is right control pad. Action. See, I am moving my wrist. But remember, as soon as your head is out, it is locked. You cannot move it now. So once your head is out, again you have to put your finger inside and then you put your head. But after putting your head, you should not directly move it. You should little tap it once. Just like your mouse, once it is lost from the screen, you have to move it to get it visualized. So if I will just put the head, I cannot move it. It is not moving. What I have to do, I have to put the head and it is giving one icon there, that means tap it. See the icon there. Can you see that? And I will tap it. Now icon is gone.
Yes, sir.
If I will not tap it like it is, then this will not move. So it is guiding you to tap it. And see, I am tapping it once. And now it is under my control. Now what I will do first, I will move the camera here. Can you see that? Camera is moving, see there. Telescope is moving. And movement of the telescope is just like newspaper. If you have to move the newspaper, you are moving both the hand like that, it is panoramic. If you are bringing it, it is close up. If you have to see right, move it right. Both the hand. But you know, at that time, camera has to be pressed. If you will not press the camera, instrument will move. As soon as you will press the camera, instrument is deactivated and the telescope is moving. So I will show you. I am not pressing the camera. Now see, instrument is moving. Can you see? Right, left,
Yes.
left, right. But suppose I am holding this. I am holding this rubber and I am taking it out. Now suppose this is out. Here. It is out. And even if it is holding there, I will press the camera. And now see, instrument is not moving.
Yes.
What is moving?
Telescope.
Telescope is
Telescope.
So I can bring the telescope here, like this. Did you see that?
Yes, sir.
And I will remove and then I can drop. So at that time, telescope was moving and I am dropping it here. And again I will move the telescope and I can correct it like this. And now again I can hold it. So this is very easy. What is your task right now? That you have to hold this and you have to bring it out without breaking this. Bring the telescope nearer. Transfer this to the right to left hand like that, and then you will practice to drop it in. You got it? Suppose I am too nearer like that and my hand is touching up. Can you see that? Now I want that it is not good, then I will press the clutch and I will go here. Now see, again my instrument is in the good position. And then again I can press the clutch and I can bring it. Normally you should use the clutch in such a way, like here I cannot go further. And you see now my hand is completely in. I will press the clutch and I will bring it here. Now I can go further. Again I will press the clutch and I will bring it here. Now I can go further. So this way clutch is used to bring it to the normal position. So this is very simple. Once you will do few times, then you will learn. So now by the time, as soon as I removed my head, now it is deactivated. So it is sensing from here. This is for a speaker. Sometimes if you are getting diplopia, there is one button here. And you can adjust. Suppose you are using specs. Then if you will adjust, then every person has a separate eye distance from one eye to another. If you see here, it is moving. Inside it is moving. Did you see that? Inside is moving here. And that way you can adjust your eye, and that is known as a spatial separation in between the eye. And that can remove your diplopia, so that you will get the proper depth perception. Here is one volume for sound. If you don't want to listen the sound of the patient card surgeon, you can decrease it. This is for sound. If you want to increase it, here. Now the sounds are visible. This AC sound also, air conditioned sound is coming. So you can decrease or increase. Right? Yes, this is audio, for the audio. So now you have to do the procedure, and I am just keeping it to the neutral position so that you will be comfortable.